Hi, good
Yeah.
afternoon, all. We'll just give it a minute. There's some more people joining. I hope that you're had a chance to get out in that lovely spring weather this morning. It's a beautiful day here. Dr. Trivedi's on the West Coast, so I always sort of just update her on the New York weather. So. You see, we have a few more people joining, so we will give it another minute, and then we will get started. Thanks for making the time to join us over your lunch break today. All right, so in the interest of time, we will get started. For those of you who don't know me, my name is Mark Graham. I'm the Vice President of Program Services at Coordinated Behavioral Care. Normally I would have a nice blue background with my name like Dr. Trivedi does. But even a year into the pandemic, I struggle with my Zoom backgrounds and I changed computers. So unfortunately it's not there and you're gonna have to see the blur behind me. But we are really delighted that you were able to join us today. Those of you who are regulars will know that this has been a series that we've been running since the beginning of the year. And it's an opportunity to meet with a healthcare expert and to put questions to her and at other times part of her team regarding areas around COVID. Those are the questions that we think and sometimes don't know where to get an answer from. Or we've heard news and don't know how accurate it is and whether, you know, like there's untruths and myths around COVID. And I think all of that has caused a lot of anxiety for our workforce. And so it's been a real pleasure for me, particularly getting over the last 6 months to know Dr. Trivedi. And I've really appreciated her expertise and her knowledge around COVID. And personally myself, I've learned a lot from it. And so we come to the last in our series, you know, I'll extend my thanks again at the end, but I would like to thank Dr. Trivedi for all that she has done. And with that, I will hand it over to her to introduce herself for those who don't know her. And what I like at the beginning of each session, she provides us a little update and a snapshot of COVID across the US and particularly here in New York City. So with that, I'll hand it over to you.
Thanks, Mark. Thanks everyone for joining. It's been a pleasure for me and my team to work with TBC during the last 5 months or so. I've really enjoyed working with the group and I'm glad to hear that the sessions have been helpful to you and the audience. So let me share my screen so we can start our update today. All right, so today we're going to talk about myths and realities, but to start off with, we're just going to talk about kind of what's going on with the pandemic, both in the US, New York City, and globally as well. So as you all probably know, cases are continuing to come down across the United States. We still have some places in the United States that have some higher prevalence of disease, but this is largely due to the percent of the population that is now vaccinated. New York City is also seeing a very similar trend with cases coming down, although I just want you to know that, you know, as of May 9th, which is when this slide is from, we're still at a level of cases similar to what we saw in October, November of last year when things started going up. So, you know, we're not completely out of the woods yet. We need to continue with this vaccination campaign that we have going throughout the country. So far in the United States, we have 32 million cases that are confirmed, and experts believe that this number is at least 2 to 4 times larger than the number you see on the screen, because many people don't actually have any symptoms, don't get tested, don't have access to testing. So we do think this number is an underestimate. We have surpassed 575,000 deaths. We're at now almost 580,000 deaths across the country. Luckily, the population that has had 1 dose of vaccine is now 58% in the United States, which is quite amazing. And if any of you have gone to one of these mass vaccination sites, it's like, especially the FEMA sites, it's like clockwork. You drive up, They give you your shot. They ask, is anyone in the car over 16 and can they get vaccinated? So it's a very streamlined vaccination approach, and it's a good experience for our country to know how to do this in the present day. In terms of the entire US population that's been fully vaccinated is close to 35% now. And then for our most vulnerable population, so the elderly, people over the age of 65, we now have close to 72% of that population that's vaccinated. And that is largely because of all the work that has gone on in nursing homes, residential facilities with the elderly. So we look at New York State itself. So New York State, the number of people in the state itself that have been vaccinated is almost close to 10 million, which is 48% of the population, and 60% of those over the age of 18. So we do have actually a significant number of 15 and 16-year-olds. It looks like they've been vaccinated in the state. And then if you look at the map, you can see that there are areas where there is a higher density of vaccinated people and then a lower density. So the lowest density is around 32% of that population is vaccinated, but in other places, particularly around New York City, you'll see that the vaccination rates are much higher. So we are seeing a difference in different locations based on vaccine uptake. So
Can I ask you a real quick question? Just looking to New York City.
Yeah.
And you may not know, but I saw somewhere, like I think it was over the weekend, and I was kind of surprised that New York City's vaccination rate was around 56%. Which yes is good as if you work towards getting, but I sort of kind of expected New York to be higher. Like we have the big Javits Center, it's an area where people don't necessarily have to drive to get vaccinations and stuff. And I was wondering, like, have you heard any reasons why like big metropolitan city like New York isn't closer to like Vermont at 75%?
Right. Yeah. I mean, I think we are battling more vaccine hesitancy than we imagined, even in large metropolitan cities. And I think that we're going to have to continue talking about why people are not getting vaccinated. It may also be that some people are not able to get time off work. They're worried about the side effects, because they can't take off 3 days from work. So I think that there are a multitude of reasons about why that's happening, but it does kind of broach the point that we may not be able to reach this kind of goal of herd immunity in certain locations. Like in San Francisco, for example, we're like 75% vaccinated in the city of San Francisco. In Berkeley, where I live, North Berkeley, I just read yesterday that in one zip code in North Berkeley, 99% of people that are eligible are vaccinated. So, we do have certain areas that have more vaccination than others. And I will say it's not always linked to socioeconomic status or education levels. People have different reasons for not wanting to get vaccinated. And we'll talk about some of those myths, I think, later in the presentation.
Okay, great. Sorry.
No, don't say sorry. It's great. So yesterday was a particularly good day, and I'm jumping a little bit, but I just wanted to share kind of some positive news that we had just yesterday. One is that, and this is literally hot off the press, so you're not going to really probably read this much in the news, nor will you read in the New York Times. But yesterday we had our first publication on a pan coronavirus vaccine, meaning a vaccine that can deal with all coronaviruses, which would eliminate the reason to have a booster, would eliminate the reason to have any kind of annual vaccine like we do for the flu vaccine. So that was a really, really positive first step towards having a vaccine that can address all coronaviruses, actually not just SARS-CoV-2, but also MERS and some of the other kind of related coronaviruses. So that was really exciting. We had a really high number of vaccinations yesterday, the highest in the month of May, and the country was really getting worried because we were seeing a drop off in the number of vaccinations. Yesterday, we also had a paper published that 90% of the virus particles are carried by 2% of people. So we've had this theory all along that there's some people that are able to spread the virus more than others. And so we're finding out that that is true, that if certain people get the virus, for whatever reason, they're really good at spreading the virus. And those people are the ones that are super spreading kind of viral particles. So the next step will be to figure out who those people are so we can really make sure that those people are vaccinated, right? And then the fourth thing is that yesterday we had the lowest 7-day test positivity rate for the US pandemic since the beginning of the pandemic. We're down to 2.9% across the country. So that's extremely positive that we're just not seeing as many positive cases. That's really good. And then the last thing I'm sure many of you know is that yesterday the FDA granted the emergency use authorization for 12 to 15-year-olds for the Pfizer vaccine itself. And so that was also really positive news. Most places are not quite yet dispensing the vaccine to 12 to 15-year-olds because the ACIP, the Advisory Committee on Immunization Practices, which is out of the CDC, will meet tomorrow. And then officially the CDC director will grant pharmacies and vaccination sites the ability to actually give vaccinations to 12 to 15-year-olds. So it could be as early as Thursday where we can start vaccinating the 12 to 15-year-olds.
So can I do, just as a clarification point, because I do have a kid, two kids who fit in that age group.
Yeah.
It's the same Pfizer vaccine that the adults are getting. So it's already sort of in our community. It's not like it needs to suddenly be shipped out from the factory and stuff. It is the exact same vaccine. Is that correct?
It's the exact same vaccine. It's the exact same dose. And yes, that is true. For the younger children, we're looking at different doses. So that one will be different. But for this age group, because we think 12 to 15-year-olds are so similar to 16 to 25-year-olds, we are doing the exact same dose. And that's what was done in the clinical trial. So it's just a matter of CVS, Walgreens, like all the pharmacies, just lowering their age. That's it.
Wow, that's great.
So I would be remiss not to mention India. India is having a huge surge in COVID-19 cases right now, and really dealing with a collapsing healthcare system. I just wanted to mention that as we have more vaccination in this country, we are seeing other countries, many even countries in Europe and across the world, who don't have access to vaccines like we do in the US, and also are dealing with COVID-19 infections to such a terrible extent where there's rationing of oxygen, there is, they're not able to get treatment in certain parts of India. So, just let's be grateful that we are in the position we're in, where we have access to these amazing vaccines. And also understand that the only way this pandemic is really going to end is if we end the development of these variants. And as we have infections and transmissions and surges in other parts of the world, those variants are more likely to develop and will inevitably come to us in the US. So it's to our benefit to make sure that these infections are controlled in other countries as well.
Can I just add sort of a question on that though? And maybe this is one of these sort of like, we're going to talk about myths and truths and stuff, but I heard, I think again over the weekend, that there was a criticism that the Biden administration was not sending surplus vaccines that they have in the US to places like India and other developed countries, and sort of the first world inequality might exist with countries that could afford them having the vaccine. Do you know if there's any truth in that the US is sitting on a surplus of vaccines that could be shared with other countries?
My understanding is early on in the pandemic, there were some contracts that were written between the Trump administration and these companies that had to get worked through in order to share the vaccine with other countries. But I do believe that the Biden administration is trying their best to get the vaccines out to other countries, especially places like India, where we can make a difference by vaccinating more people there and getting infections under control. Because when I was so I used to work at the CDC, and I did a lot of work internationally. And I had some people ask me, why is the US government funding our own public health service to go out to other countries and deal with public health emergencies? And the answer to that is, we are a global economy, a global world now. Anything that happens in other countries will eventually affect us. And we learned that with Ebola, and we've certainly learned that now with COVID. So it does behoove us to help these other countries, because if variants develop, that will end up being a problem for us, and especially if they outwit the vaccines that we currently have available. So one thing I think we talked about this last time, but I thought it was good to mention this again. This is a topic that I keep bringing up with clients and patients. It's around harm reduction. And it's something that many of us really understand, especially as we talk about hepatitis, HIV. I'm sure many of you in behavioral health, you understand that there are some things people are still going to do, some certain high-risk behaviors that we may not be able to eliminate, but we maybe can modify to decrease risk. So I think we really need to think about harm reduction. As we continue to grapple with infections in parts of the country, it doesn't appear that people are willing to stay indoors and not interact with each other anymore. So how can we message in a way that reduces harm, but allows people to still enjoy their life, right? So harm reduction, I think, is really, really important as we continue to deal with COVID-19. And then, of course, battling misinformation. Misinformation is around us, and it's not necessarily that the sources of the misinformation are meaning to be inaccurate. It may just be that they have outdated information. I'll just say, as somebody who's been teaching others about COVID-19, often the thing I'm saying on one day is outdated by the time I say it the next day because something else has happened, or there's been a new paper published that invalidates something we thought before. So it's important to understand what your avenues of information are. And it's important to trust certain people in the community, right? Like figure out who you trust, what information sources you trust, and really, really focus on those. So this COVID misinformation has become a real problem, and we're going to address some myths later today. And so in terms of potential solutions, what I like to do is I like to listen and acknowledge and validate what the questions are, what the myths, not just laugh and say, oh my God, that's ridiculous. That's not true. That's not a way to get people to believe you. So you have to listen, acknowledge, and validate, educate and dispel myths, and engage with the community on whatever the issues are. There are certainly, especially in the Black community, the Brown community, there are some real issues with vaccine hesitancy, and they're completely understandable given our country's history with the Black population, especially in the healthcare system. So we have to understand that, and we have to engage the communities, and we have to help people feel a sense of empowerment and control over their own health and their own health decisions. So none of this is meant to strong arm anybody. It's just meant to give some good information for people to listen to and to absorb.
And I think just to say with that, communities of color, and I think the hesitancy that people have spoken of before, and certainly given the history, but I think it's also worth noting, from what I've read anyway, that sometimes along political party lines, there are certain states that people, for almost political reasons, are choosing not to get vaccinated. And I'd heard from someone, it's like, we hear a lot about the communities of color, and it almost becomes like a blame game. Well, if they were all to get vaccinated, we get the herd immunity. But it's important that it's not just communities of color that may have reasons. There's other people out there for political reasons, perhaps.
Absolutely. Yeah, I think the Black population, we've done a really good job actually of addressing vaccine hesitancy within many Black communities. There has been a real push with Black doctors, Black celebrities to educate communities, like, for example, Tyler Perry, like to educate communities about why they should get the vaccine, that this is not like Tuskegee, where a treatment was withheld. This is actually the prevention you want by getting the vaccine. So it's not a parallel with the syphilis studies that were conducted. So no, we made a lot of inroads with the Black community. We have not done as good of a job with Republicans. So we are seeing this blue state, red state gap with vaccinations. And luckily we are seeing some political members of the Republican Party that are stepping out and saying, no, you should get vaccinated, but those voices are not as loud. We will see what happens with infection rates as they increase, and if red states do end up having more infections than blue states end up having. But we are seeing that gap certainly right now.
So as we jump over some sort of questions, and sort of format that we've had, that people have submitted questions to myself before and my colleagues at CBC, and we're going to run through some of those. But on the day of, like today, please submit your questions in the chat box. I see one already from Bob, and I will get to that. And we keep a track of them as we go through. But if something springs to mind, please, by all means, just put it into the chat box, and we will answer it. So we wanted to touch on a few sort of myths that have been circulating around COVID over the last 12 months or longer. And the first one, it's one that emerged very soon after the spread really sort of came to the US. And it was that, like, where does something like COVID-19 suddenly spring from and come from? And there was reports of that it was being transmitted by bats, and that in parts of the Asian culture, people were eating bat soup. And that was the reason that we were now getting sick, and then they were spreading it. Is there any truth in that?
So I think we do know that there was movement of this virus between the animal reservoir into the human reservoir. I think that is true. I think, you know, we see many viruses move in this direction between the animal reservoir to the human reservoir. And we study, remember swine flu, we study how this this transmission happens. We also need to realize it's kind of a reality of, again, a global community. So, but I think in general, I think the point is, you know, can you get COVID-19 from food now? No, you cannot. There is no evidence to suggest that handling food or consuming food is associated with getting COVID-19. And I think, you know, how the virus went from the animal reservoir to the human reservoir is probably not new for us. We grapple many infectious diseases that move in this direction.
So with that, you know, summer's obviously on the horizon. Mosquitoes, like I've heard also that can spread the virus from human to human with the blood. Is that any truth? Or
I have not heard that. I have not read any studies about that. So that would be similar to like malaria, which is a parasite. And I have not heard that, you know, again, the mosquito would have to have the virus in their body and then transmit it to someone else. It seems unlikely, but I have not read anything. I did look when you sent me the question, and I haven't seen anything around that. So I don't think there's any scientific justification to be worried that that is a real threat at this point.
Okay. And the other one about transmission was, and I remember this time last year, I think we were all washing the goods and stuff that were delivered, but it's like, can COVID-19 be transmitted from goods produced in another country where there's a high ongoing transmission rate? So say something from India now that was shipped to the United States. Right. Is there a risk?
Yeah, no, there really isn't a risk. I remember my parents were actually in China, visiting China at the very beginning of the pandemic, and they sent my nephew a birthday card, and everyone was like, don't touch the birthday card, it came from China. No, so that's not true. We did originally, so the rhetoric originally was that you could find virus on cardboard and glass. I'm sure people saw those charts with, you know, for 5 hours on glass and for 24 hours on copper and things like that. So it is true, you can find virus on different surfaces for longer periods of time. I think cardboard was 24 hours. However, we have not found any transmission occurring because of this virus. So you know, you would have to have virus on the surface that you then touch that was viable. Then you stuck it in your eye or stuck it in your nose or stuck it in your mouth, your hand, and then you would have enough viral load to get an infection. We haven't seen any infections happen because of that. So we are not recommending that people need to do all the things that we were doing early on, like leaving your Amazon boxes sitting in your garage for 2 days. You don't need to do that. We do not believe that that's the predominant form of transmission. We believe the predominant form of transmission is via respiratory droplets. So even if the virus can live on the surface, we don't believe that there's enough viable virus there to actually cause a true infection.
Thank you. And then the other one that I had in relation to the vaccine itself, and I find it sounded funny because, you know, as we're now more talking vaccine, it's sort of shifted from what caused COVID and transmission. But a couple that came up recently about sort of vaccines. One, and I think this maybe impacts some of the religious communities, was that the vaccine is made up of an aborted fetus.
Right. Oh, wait, let me mention one other thing as I leave the contaminated surface one. So once you do have somebody in your house that's infected with COVID-19, it does seem to be still a good practice to disinfect household surfaces that they might be touching. So doorknobs and things like that. Because if you have an actively infected person, you may have lots of droplets with viable virus in the environment. So that would be the only situation where I would be wanting to disinfect, you know, household surfaces. High touch surfaces should probably always be clean, because we're, you know, as we open doors and knobs, as we walk into office buildings and different places, those things should always be clean, so we're not transmitting any viral infections that way. So sorry, I just wanted to mention that.
Sure.
So in terms of vaccine myths, so yeah, there are lots of just myths that are easy to dispel because they're not true. So down here, the fourth one I have is, were aborted fetuses used in vaccine creation? No, they were not used in vaccine creation. Does the COVID vaccine contain live virus? It does not contain any live virus. Can I get COVID-19 from the vaccine? You cannot actually get the infection from the vaccine, especially the mRNA vaccines, because those don't actually have the full virus there. The Johnson & Johnson vaccine is an inactivated virus that cannot be reactivated. It's been engineered to be inactive. So you are not getting a dose of real virus at all. For those that are vaccinated, will exposure to COVID-19 reduce the efficacy of the vaccine going forward? No, you know, that's not true at all. So if you get vaccinated, we know now that, you know, at least 8 months down the line, you're still protected from further infections of COVID-19, at least with the variants that are currently circulating. And then the last one I have here, vaccines are unnecessary for people under 50 with no underlying health conditions, as they only get mild cases of COVID-19. I would say this is also not true. That we have, as a physician, I have seen people under the age of 50 die of COVID-19 with no underlying medical conditions. You don't know how your body may do to this when it comes into contact with this virus. And then secondly, even if you get a mild case, you are able to spread it to other people. So you may end up spreading it to a child who's unable to get vaccinated, or people who are more vulnerable, and then they end up having severe disease. So it's important for all of us to get vaccinated when we can.
Okay, thanks. There's two others that I had sort of on my list here. I don't think you covered them. But I've heard that there's a rumor that the vaccine may cause infertility. Have you heard that?
Yes, and I have this about safety and pregnancy, but no, there is no feeling that it causes, or there is no data that it causes infertility. When we looked at clinical trials of all the vaccines that are currently available, there were some women who became pregnant during the vaccine trial, right? So there were some women who, just because that's the natural, you know, state, you end up getting pregnant as you are in the vaccine trials. And when we looked at rates of spontaneous abortions, so miscarriages that occurred in the vaccinated participants versus the placebo arm, we found that rates were exactly the same. So we didn't think that, it does not appear from the clinical trials that people that were vaccinated were unable to get pregnant compared to the placebo arm, nor did it look like they had a higher rate of miscarriages or stillbirths based on the vaccine. So there is that is a real myth that I hear a lot about infertility. And then this is just another, this is some data published just last month from the CDC, looking at over 35,000 women who received the COVID-19 vaccine before or during pregnancy. Pregnant people reported similar side effects after vaccination. There were no particular safety concerns for people vaccinated in their third trimester. And the other thing that they noted in the study is that there were some antibodies that were delivered to the babies, to the infants when they were born, that can battle COVID-19. So in fact, it may be not only safe for pregnant women, but it may be even beneficial to their fetuses and then their children when they're born to have vaccine themselves. So I think the other thing to note too, Mark, is that if you are pregnant, you are at risk of having potentially a poor outcome from COVID-19. So pregnant women are at high risk for having poor outcomes themselves. So that's why the recommendation is, if you're pregnant, you should strongly consider getting the COVID-19 vaccine, because it will protect you from having a severe outcome and will also protect your child.
So I had a sort of a follow-up to, and it's not on your list there, but so it's related. I had heard that it's not safe to breastfeed once you've had the vaccine.
Nope. So again, that's not true. So let me just go back to the vaccine. The predominant vaccine that's out here today in the US is the mRNA-based vaccines, the Pfizer vaccine and the Moderna vaccine, right? Those two vaccines, what they do is they introduce into our bodies a piece of genetic material that is of the spike protein. So it just shows the body a part of the virus, not the whole virus, a part of the virus. Then our bodies develop antibodies. Now, remember, this is something our bodies do all the time. When we encounter a new virus, when we encounter a new pathogen, our bodies are always doing this. So all we're doing with this mRNA-based vaccine is we're introducing into the body this piece of genetic material, and then we're allowing the body to then do what it usually does, develop antibodies. So we're not doing anything kind of abnormal, really. And the mRNA-based vaccine is covered in a lipid layer. So it's like a fatty molecule with this mRNA genetic material in it. And then that actually dissolves. So the original vaccine it's like one of those instructions that, that James Bond used to get, and then it would like self destruct. It's like that. It just self-destructs. So in and of itself, the vaccine is not staying in your body. It dissolves, it goes away. It's no longer present. And instead you have all these antibodies in your system. So and then breastfeeding, actually, as we all know, breastfeeding transmits antibodies that the mother has to their child. So again, this is another way that we can help protect our babies by breastfeeding after we've been fully vaccinated.
So to move, so like, I suppose, another question, and this is not so much a myth or something like that, but for a fully vaccinated family, say my own family in a way, or like my wife and I are vaccinated.
Yeah.
How safe is it to have people in who are not vaccinated, who've chosen not to for whatever their particular reason is? That, like, are we at risk? Like, I mean, it's like, when we start to look at this reopening business, we're going to talk a little bit more about that. Oh, this is a good graph. Yeah, this is good.
So this is from the CDC from a couple of months ago. Or no, I mean, like, time is so warped. Maybe last month. So we think, first of all, think about your bubble, right? So you and your wife, let's take you guys as an example. You and your wife are now vaccinated. Because of that, your children are actually safer than they were a few months ago, right? Because the adults in their lives are now vaccinated. So you are not able to you're at low risk to transmit the infection yourself to them. So they are safer. So you have made your house safer for the people in it that cannot get vaccinated. I think that's a really important point. So if you are interacting with one household where you believe that the people in that household are at low risk of having a complication from COVID-19, this chart, this infographic from CDC, it would be the top. So first, let's just go step by step. So the first step is 2 households that are completely vaccinated, right? So in this case, it would be basically 2 families with kids over the age of 16 where everyone is vaccinated, right? That's not usually the situation, but let's say that is. In that situation, 2 households can completely merge and not have any prevention methods in place. You don't have to have a mask on. You don't have to have this. You can just act normally, right? Pre-pandemic, normal. If you want to interact with one family, so I'll give an example about a set of grandparents, right? Let's say grandparents who are vaccinated. This is happening a lot across the country. Grandparents who are vaccinated want to interact with one of their children, and their children, the 2 adult children, are vaccinated, but their kids are not vaccinated, right? So they're essentially an unvaccinated household. If you determine that this unvaccinated household is at low risk because the kids are at low risk for whatever reason, they don't have any underlying health disorders, it is completely reasonable for those 2 groups to interact normally, right? For you to sit down at dinner, no masks, be close, hug your grandparents, all of that. It gets more complicated when you start dealing with a family who's unvaccinated, where there are people who are at risk of developing poor outcomes from COVID-19. So if you have a child, like let's say, who has an underlying health condition, maybe uncontrolled diabetes, uncontrolled asthma, in that situation, even if one household is vaccinated, the recommendation is it's better for everyone to still keep up with some of these prevention methods, because you are trying to protect that child who is unvaccinated and who is at high risk. And then the last thing is really multiple households. So if you have, I still, for example, am a little wary of us merging with like a set of grandparents plus another family who have both have unvaccinated children, because I feel like that is introducing potentially, unvaccinated children in schools. You're maybe introducing too much risk in that situation, but some families are okay with doing it. Right now, the recommendation from CDC is if you do that, they would still recommend some of the infection prevention methods.
So can I just ask you, with that last example of multiple families and with unvaccinated kids?
Yep.
When you say who's the risk to? Are you like the grandparents are in their 80s and vaccinated? Like, is the risk to them? Because let's be clear, you can still catch COVID even though you're vaccinated. But we hear it's going to be very mild if you are. Like, so I'm just curious, like who are you considering the risk there?
Yeah, I think I'm more worried about if you are talking about kids, you're talking about kids that, so it could be kids that are unvaccinated that are high risk, that I would worry about them getting infected. Again, because you don't know what the outcome might be. I mean, most kids are doing pretty well with COVID, but some kids don't. So that's where the risk is. I think the other thing with grandparents, unfortunately, is because older people were not able to mount as robust a response as younger people. You still, if you have multiple households of unvaccinated kids, you may still want to implement some distancing, some improved ventilation, some masking. The risk is mostly to the people that are unvaccinated, not to the people that are vaccinated.
Okay. That helps. I got a little anecdote story. We got together with a couple of little households where all the parents were vaccinated, and we just left the kids in the backyard and closed the door. And they had the outdoor space, and we actually made the kids continue to wear masks because they're at this stage they're kind of used to it. So it was like an element, but to them it was a normality. They were able to see people they hadn't seen in a long time. So, but we left them outside with masks on. So.
No, and I think this is kind of that harm reduction that we were talking about earlier. It's really important for kids to see each other. It's important for kids to be interacting with their grandparents and with other adults. And so I think you have to ask the other households you're merging with, what feels comfortable to you? What works for you? And then that sounds like I'm completely happy to have any vaccinated person come into our household. Completely happy with that. It's when we get unvaccinated children, since my children are still unvaccinated, where I get a little more, a little nervous. And so I ask them just to be outside, wear masks, distance, keep the windows open. You can do all those things. And, now that the 12 to 15-year-olds are about to get vaccinated, we're so close. So once they get vaccinated, then the next age group is actually much lower in terms of risk for infection. So with that age group, we'll feel even more comfortable to let them come into our house because they're really at low risk of having transmitting infection and getting infection themselves.
So in the chat box, there is something about what constitutes unvaccinated and low risk. The example Dr. Trivedi gave of people under 50, no underlying health condition, still dying of COVID, makes this category seem like a moving target, which is good, very good point.
What constitutes? Let me just read it one more time. What constitutes unvaccinated and low risk? Yeah, so it's an individual risk assessment. So if you are 50 and you have, so no underlying health conditions, that's what she's saying. So when I look at risk, when I look at transmission rates, I see rates change at the age of 12. I see 12 to 17-year-olds have transmission risks, infection rates similar to people over the age of 16. And between 16 and let's say 50, I see higher transmission rates than I would like to see. That's just what I see. So for me, there's a big change between 2 and 11 and 12 and over. So once the 12 and overs are vaccinated, I feel like that is a much safer situation for us to be in. And also, quite frankly, the 2 to 11-year-olds are really good at wearing masks. I think the teenagers are not as good at wearing masks. So you ask the 2 to 11-year-olds to continue to mask, I don't think it's a problem. So you do have to do an individual risk assessment to determine, who is low risk and unvaccinated. I think the general guidance is, uncontrolled diabetes, uncontrolled asthma, obesity. These are all risk factors that increase your risk of developing a poor outcome from COVID-19. I hope that's helpful with that.
So, because that's what I wanted to move on to. So it's this idea of how pandemic actually eventually will end and return to office. And I think, we're hearing from yourself and from others that we get more and more people vaccinated, and that's what's ultimately going to lead to an end. And these new sort of findings and stuff are very promising. But going back a little bit to your blue and red states, so I heard that New Hampshire, Vermont, a lot of the New England states are up to 70-75% vaccinated, well ahead of what the hope was of July 1st. But then I hear Mississippi's down at like 42%, and then Louisiana is like in the lower. And so do we get to a stage where it's like, and I think back to Bob's question at the beginning, what like, are some of those, they also tend to be some of the states that are opening faster. And is that just going to create this ongoing circle of COVID cases because you've now reopened their economies for whatever reasons, and yet they're the state with the lowest vaccinated rate? Do you know what I mean? Like, are we ever, we're just going to go in circles?
Yeah. So I think early on in the pandemic, there was a lot of talk about herd immunity. We've even talked about it on one of these webinars where we talked about getting to herd immunity, which is enough community immunity where the virus can't go to another person, right? So you have enough of it that the virus essentially fizzles out. I think now we've realized, because of all the vaccine hesitancy in many parts of the country, that we may not be able to reach herd immunity, that might not be attainable. So now we're talking about the path to normality. So there's a famous data scientist that originally was talking about the path to herd immunity, and now they've changed it to the path to normality. And the idea here is that COVID-19 is a pandemic, as you all know. So the word pandemic means it's everywhere, right? And it's an epidemic where it's way higher than we see normally. I mean, this is a brand new virus, so we've never seen it before. But there will be a time where it becomes endemic, where there are increases in infections in certain places. People are going to have to put their masks back on. They're going to have to distance, maybe even having some shutdowns again. We are going to kind of see these cycles of transmission where it becomes endemic. You have little outbreaks, maybe in schools, maybe outside of schools, maybe at camps. But for the majority of the time, we are living normally, without masks, without distancing. And it may be that occurs in different time points in different places, right? So in places like North Berkeley that I just mentioned, where 99% of the adults are vaccinated, they may be able to get to that point of normality much faster than, let's say, communities in Mississippi. And also, it's not true. I mean, if you look at Texas released their mask mandate, a month ago, before they had vaccine. They even were close to, higher percentage of vaccination. So I think that, the politics is going to dictate what happens in a lot of places. But public health, generally, the public health departments, local, state, national, I think we'll have some sort of threshold to say, once your community has reached X percentage of vaccination, we are saying you can take your masks off and interact outside with, without masks on, or inside without masks on. Fauci, even over the weekend, talked about that happening relatively soon, if you heard him say that. So, but I think it is going to be dependent on the community, because we are seeing different rates of vaccinations in different places.
So, and to that point, because I did hear that over the weekend about sort of dropping the mask, if you will, and this sort of lends to returning to work, particularly in New York, where we commute, most of us, on public transport. I'll put myself out there. I don't know whether I'm ready to go without a mask on the subway. Like I feel it's almost been ingrained in me now that if I go somewhere and someone is not wearing, I have an increased anxiety. If I see them in a grocery store or something like that, I just don't, and so I wonder with our wider workforce here in New York, like, how do you, I feel there's going to be a lot of anxiety and stress in the coming months, even though things are under control.
Yeah. So I think that, we have nipped flu in the bud this last year because we all wore masks and we distanced from each other. So there are some really positive things from the infection prevention measures that we already have in place. And I think, wearing a mask on the subway, period, even if you're vaccinated, not wanting to get infected with other viruses is okay if that's what you feel is comfortable for you. I think at this point, Mark, I would recommend people still wear masks even if they're vaccinated, just to be polite in especially in an indoor space, right? Actually, let me go back to this one slide. Sorry, I hope I'm not making anybody feel sick going through the slides real quick, but there was this, let me just show this one other infographic from the CDC that might help inform this discussion. Yeah, choosing safer activity. So this was published last week, the week before maybe. And this is about that, about what you're talking about, can I walk around outdoors without a mask? What if I'm not vaccinated? So CDC has really clearly outlined what they recommend for people that are fully vaccinated versus people that are unvaccinated. And you can see all of the outdoor activities. They're recommending you don't have to have a mask on if you are a fully vaccinated person. So see on the right-hand side of the screen. So anything outdoors except for attending a crowded outdoor event, like a live performance, a parade, or a sports event. In that situation, you may still want to consider wearing a mask as a fully vaccinated person. And that, again, is not because you're protecting yourself. It's because you're just being polite to other people. Right. That's why you're doing that, right? But for an unvaccinated person, they're even saying walking, running, or biking outdoors with members of your own household, you don't have to wear a mask. Attending a small outdoor gathering with fully vaccinated family and friends, you don't have to wear a mask. So there are situations where unvaccinated people can also consider taking their masks off outdoors. Now, indoors, you'll see the bottom half of the infographic is everybody should be wearing masks. So indoors right now, we're still recommending for fully vaccinated people and unvaccinated people to wear masks because you don't know who's vaccinated and who's not vaccinated in that situation. So it is a politeness kind of factor at this point. So I think that kind of helps inform that. And in terms of returning to work, sorry, let me go back to this slide again. So I think the travel is an interesting question about, how people feel comfortable traveling. I think you have to figure out what works for you, what you feel comfortable with. I think wearing a mask in a subway seems like a reasonable thing to do. And in terms of working back in the office, we do think it's best if the workforce is fully vaccinated, right? Obviously, it'd be best if everyone around you was fully vaccinated. And also if your patients and clients are vaccinated as well. That is the best case scenario. Now, there are many patients, many clients who cannot be vaccinated for whatever reason or do not want to be vaccinated. You being vaccinated, though, is really going to protect you and certainly protect your unvaccinated client from being at high risk from getting the virus from you. So I'm consulting right now a lot with offices that are thinking about how do you mix vaccinated and unvaccinated people together in one space. And this is where we come back to this layers of Swiss cheese, right? So if you remember from many, many webinars ago, we like this concept of Swiss cheese. So Swiss cheese has holes in it. But as you layer multiple layers of Swiss cheese, so you layer vaccines with masks and hand hygiene, you layer all these different Swiss cheese slices together, you don't have any holes going through the slices anymore, and therefore you don't have as much transmission. So I think offices are grappling with what are these layers of Swiss cheese? Have I improved the ventilation in my office space, right? Have I made a symptom screener so that people only come into work if they have no symptoms or signs of infection, right? Do I have a process whereby if there is an exposure, I can notify everyone and everyone then can quarantine and isolate if they're not vaccinated? So do I have a testing program? There's some office spaces that are going to require a rapid antigen test when you walk through the door. So I think different offices are looking at which slices to put into place. Which ones can they do? Can they put up plexiglass, in between?
But can I ask you about that? Because I heard about the plexiglass.
Yes.
That it's just all for show. And so this came up with New York restaurants reopening, and someone said this plexiglass in between one table and the next, and it's like you think the virus stops when it reaches here, that it doesn't sort of carry over, and like that it's just doesn't serve any purpose other than to give the sense that it's safe. Is that true or?
No, I think plexiglass. So the idea, it depends on how high the plexiglass is really. Like if you stand up from your booth and your head is over the plexiglass and you're able to like look right down into the next booth, and that probably is not very effective. But it is remember, physical distancing means the virus, because this virus is not that. There is some aerosolization, but the virus generally drops around 3 to 4 feet away from people if they're coughing, if they're sneezing, if they're talking. So if you do have a barrier in between let's say one restaurant booth and another restaurant booth, that virus won't be able to get as easily over it. Does it mean that there's no transmission? Probably. I mean, if I have a lot of virus and I'm one of those super spreaders, it is possible that I'm talking, the virus aerosolizes, it goes over to the other person, but it still has a little, there is some distancing or physical barriers that have been helpful to limiting transmission. So I don't know if I would say plexiglass is actually quite expensive. So if restaurants are putting that in place, I think it's something crazy like $1,000 a square foot. I mean, it's very expensive to get plexiglass in place. I do think that there is something to physical distancing though, and I think that those barriers can be helpful in limiting transmission.
So going back to so physical distancing, and maybe you stagger employees coming in. I've heard of one university that is requiring all students that return in the fall to document they've been vaccinated. Can an employer, can your employer ask you to do the same?
Yep.
Do you know law-wise or legally?
Yeah, it's a great question. So it appears that our government is saying that they will not require it. So the government is saying they're not going to require vaccinations, but the private sector absolutely can. So what I have been seeing, and the reason they can is because we're still in the middle of an emergency. So there is a legal means by which they can say, in order for us to operate safely, for us to provide a safe environment for our employees, we're recommending or requiring everyone be vaccinated. That is something that employers can do legally, especially because we're in the middle of a pandemic. However, what I'm seeing is the private sector with my clients, with a lot of different groups I'm working with, that they're trying not to require it. They're trying to encourage it, right? So there's a difference between encouraging and requiring. Americans generally don't like to be required to do anything. So they're trying to provide education, kind of like this session, just to encourage people to get vaccinated. And then I've had other clients, and I've heard of other offices that are saying, in order to come back to work to the office, and not work from home remotely, you have to be able to show us your vaccination status. So for example, Salesforce in San Francisco, they're saying you can't come back to work unless you're vaccinated. You can work from home if you're unvaccinated, but you can't come to work if you're vaccinated. I think some professional sports, I'm sure you guys know, professional sports teams that are requiring proof of vaccination or proof of a negative test to attend sporting events. So for example, the Miami Heat, to go to a basketball game, to go to a certain part of the stadium, you have to show your vaccination status. You have to show that you're vaccinated. And those are better seats in the stadium than for the unvaccinated. And then, other things that we're seeing, like similar to influenza. So in hospitals, right, in clinics and some hospitals, if you have a patient-facing job, the institution requires you to be vaccinated so that you do not pose a risk to the patients that are coming in. And I think this is actually a really interesting point, Mark. We've had a couple of nursing home outbreaks occur. One in Kentucky, one, I can't remember the other state. And the reason we had these outbreaks occur is all of the residents were vaccinated. However, because they were elderly, they didn't produce as much of a robust immune response, like I was mentioning before, in the grandparents. And because staff were not vaccinated, staff got the infection and then transmitted it to the patients, the residents in the nursing home, and then there was an outbreak. So I think it is really important for healthcare providers to strongly consider getting vaccinated so that they don't pass it on to their patients and their clients. And then the last thing I just want to say is an attestation. So one way I've seen people get around kind of requiring vaccination, some employers, is I've seen them require an attestation from their employees. So they say to them, you need to sign this form saying that you attest that you have been vaccinated. And if we need to see your vaccination card, you will show us your vaccination card. Because the other thing you have to remember is once there's an exposure in the workplace, in order to determine who gets quarantined and who doesn't, you need to know their vaccination status. So at some point in the workplace, there will need to be a public health reason to know people's vaccination status.
So many questions, and I do want to encourage people who are listening in to, if you have questions for Dr. Trivedi, to put them in the chat box. But yeah, so which one to go with first?
Yeah.
That last one there, just you're saying that like if someone tests positive for COVID in the office setting, you want to know who's vaccinated so you can quarantine those who are not. But yet we hear that I've been vaccinated, I can still pick up COVID, correct? So why wouldn't I be forced to quarantine as well?
So, okay, maybe I have a slide on breakthrough infections. 1 second. Yeah, so it is true. Well, actually, let's step back for one other minute, because I think somebody else had to send in a question about transmission. So I just want to show that the data is really strong right now that these vaccines prevent transmission, reduce transmission significantly. The largest study was done in Israel that showed there's a 94% reduction in asymptomatic transmission. So there's a very low chance that you're going to transmit the infection to loved ones when you yourself have the vaccine. Okay, so that's one really important point, that we have multiple studies now showing us that transmission is markedly decreased. And the reason that it's not 100% is because different people's immune systems react differently to these vaccines, right? So the robustness of the vaccine, of my immune response, may be actually different from yours. So that's why we have this difference in transmission. Okay. So now let's get to this breakthrough infections question. Should I pass it again? Yeah. So far, we know 95 million people in the US have been fully vaccinated as of April 26th. And of those, CDC it's been reported to CDC that 0.01% of people have had breakthrough infections of those 95 million people. So that's a really, really low percentage. So of course, there's a chance you could get the infection after, but there's a low chance it's going to happen, number one. And number two, if you get it, most likely it will be a mild infection. It will not be a severe infection or
just to be devil's advocate, which would suggest that maybe that number of 9,000 is probably not accurate, because there's probably people who had a mild dose of something, didn't know what it was, or it was just a cold, or what it was. So probably more people, there's probably been more breakthroughs, right?
Oh, you mean because the numbers, because people aren't showing up?
Well, people just like if I had a contracted COVID, so to say, since, like, you know, I may not like gone to the hospital, I may not have got tested because, you know, I just lay in bed because I wasn't feeling too bad. So, so I wouldn't be counted here.
It may be a little bit higher. I think though, in general, from all the studies that we've seen, I think the vaccines are, let me show you this other graph, Mark. I think the vaccines are actually really remarkable for preventing infection. And it may be that some of those people that have breakthrough infections are elderly people. It may be that some of those people just didn't develop as much of an immune response. And we're not quite sure why some people do and some people don't. You know, like you've heard of some people that don't have any side effects after their second dose, and other people that have a lot of side effects. You know, we think generally that people that have a lot of side effects, it's because they're developing that, you know, a high immune response. But this is just showing you efficacy versus safety, right? So this is showing you compared to other vaccines. So in this graph, what you're seeing is efficacy on the y-axis and safety, or, you know, vaccine reactions on the x-axis. And if you look at flu, so you see the number of flu. So flu is here in the, you know, the left bottom corner, right? So flu had a smaller number of people in these clinical trials, not as effective, low rates of systemic vaccine reactions. But look at these, the Johnson & Johnson one, a huge number of people in these trials. Pfizer, Moderna, much larger number of people in these trials. So the vaccines that we have out there right now, the pneumovax, shingles, flu, we tested them in lower numbers of people than we have these other vaccines. So just let's remember that, these vaccines have been trialed in many people, and we of course are looking at longitudinal data to see what happens to them, but we have really positive outcomes with this many people not getting infected this many months down the line.
Cool. So the other question I had, when all these questions ahead, was back to your sales force in San Francisco.
Yes.
If I worked there, I'd be required to attest or show that I had the vaccine in order to be in the office. So does that mean at the Salesforce office, it's maskless, it's no social distancing, it's one big party?
So that is what's happening. That's what's happening in places where they're requiring vaccination. They are saying, we can just be normal. We can just act normally in the office. And now, is there a risk still? Very low, very low. And maybe if you are a vaccinated person who, let's say, has an underlying immunosuppressed condition, you may still go to the Salesforce office with a mask on. You may still decide, for me, I'm still going to wear a mask, but I'm vaccinated. I'm just still going to wear a mask. I think that individual decision still, it's kind of like what the person asked. I think somebody asked in the chat, you have to make an individual risk assessment yourself. But from what we understand of the vaccines and of breakthrough infections and variants up till now, we think that all people that are vaccinated can probably interact with each other without any of these additional prevention methods in place.
So just to take that one step further. So the Salesforce, I'm sure they have a lovely big building in San Francisco. The escalators can be packed like they used to be, or like in New York, you have the corners that people are meant to stand in. And one step even further than that, if you're in a shared building, because if you are, like, it's not just Salesforce, but if you're on the 4th floor and everyone's vaccinated, but you're going up and down, I assume you adhere to the building's regulations, even like it's like wearing the mask just to support those who were to show people your support.
Yeah, no, I think it's a really good point. I think that the bottlenecks are where you have to worry about people interacting. Now, I actually am not working with Salesforce. I just know this from the news, but I imagine the Salesforce building is just Salesforce employees in the whole building, but we have many office buildings throughout the country where there are lots of different groups that are mixing together. So the recommendation would obviously be in the elevator, in the restroom where you're sharing with other people. In those places, you still want to wear a mask. And you still ideally would like to limit the number of people that are interacting in the lobby, on the escalator, especially if you have unvaccinated people that may be in that bunch. So the other thing I put up on here is that, can I take my mask off when I'm alone indoors? Of course, if you're in your own house, you should take your mask off when you're indoors. But if you are in an environment with a poor ventilation, which is typically office restrooms, typically office staff kitchens, elevators notoriously have poor ventilation. So if you're in any of these shared spaces with, even if you're by yourself, it is recommended that you still wear a mask, because if somebody could have been in that elevator just before you, coughed, and there could be aerosols in that elevator. So I still recommend in publicly shared spaces to wear a mask in these areas that could have poor ventilation.
Because I had questions about the kitchen, actually, the staff kitchens and lunchrooms and stuff. And the sense, like, I'm thinking my own office, there's an area where people can sit and have lunch together. Almost like being in a restaurant, but like obviously to eat, you take your mask down. And so I hear mixed things, because my kids' school won't allow them to eat lunch there, probably because they're all not vaccinated. But here at the workplace, can we be expected, or should we be closing off our kitchens for people to sit together and have lunch?
Yeah, so up until now, I have been recommending that until we, had enough vaccinated people. I was recommending that my clients take their lunches outdoors if they wanted to eat together, and sit outdoors and sit 6 feet apart because their masks are off. So most of I think these staff rooms, kitchens have not been really that utilized. But I think now, if you do have a predominantly vaccinated group, you could consider sitting in the staff kitchen together. But again, everybody, if you are mixing unvaccinated and vaccinated folks, which is generally the case in a lot of these places, then I would recommend, again, people try to eat outside, try to distance, having fewer number of people, and making sure the ventilation is improved in these staff kitchens. All of that, I think, is imperative to make it safe when you take your masks off.
Cool. So I'm going to ask again if anyone has questions to put them in the chat box. But of course, my mind just sort of rattles them off. But there's one I have, like, just again about safety and returning to work. I had a vaccine in January.
Mm-hmm.
I haven't read studies of when I will need a booster. Will I ever need a booster? And so how safe is it for me to sort of be going in and out of New York? And then suddenly, when do I know when I get sick? Like, when will that guidance come out about boosters?
Yeah, so as of right now, we don't believe that boosters will be necessary in the near future. This is because, let me get to this.
The one said it was 6 months, I thought someone had said, and I was like, oh wow, that's not that long off.
So first of all, and let's talk about the variants, because the variants are the reason that we would end up needing a booster, right? So if you look across the country over time, you'll see that the variants, this is from the CDC, the variants have changed in terms of the frequencies of variants in different locations. So you can see by the April 10th mark, the majority of the lineages we're seeing in the US are the B117 strain, which is the one that's originally isolated in the UK. And this was not the case if you looked back in January, right? So over a 4-month period of time, we really have seen the variants change in the US, the ones that we were picking up here. But if you look at the vaccines that we have available, you will see that lab studies and even some randomized clinical trials have showed us that the vaccines that we have available are active against the variants that are circulating. And so this is true for the B117 strain, which is the one that we are probably grappling with the most in the US. It also is true for the B1351 strain, which is the one that was originally identified in South Africa, although it does appear that the antibodies may be slightly lower with the B1351 South African strain, which is why Moderna and Pfizer are trying to develop a booster against the B1351 South African strain right now. But the vaccines we have are still active against the P1, which is the one from Brazil. The New York one, which I'm sure many of you guys are most nervous about, is the one that it was developed in New York, the B1526. All of these are we find that in the laboratory studies, the mRNA-based vaccines are still active against all of these variants.
So just to be clear, the mRNA or the Moderna, the Pfizer, that's what that stands for when you see it there. They don't.
Yes.
I'm used to the names of Pfizer and Moderna, but just to be clear.
So yeah, mRNA is the Pfizer and the Moderna vaccine, exactly. And then the J&J vaccine hasn't been studied with a lot of these, but the J&J vaccine has been found to be active against the South African strain. So I think we won't need boosters until we see that there are some variants that the current vaccines are not adequate against. And so far, we are seeing that the current vaccines are really good against all of these variants. So
can I ask a real dumb question? It's sort of I'll call it my sort of question. So the vaccine I had Moderna. It doesn't when I saw some sort of boosters, I think that it's failing in my system, or it's thinning out, that the vaccine itself isn't as strong, so I need a booster in order to top up the vaccine I currently receive. But that's not what I'm hearing you say.
No. So two things. So you want to know, is the vaccine still active against the variants that are circulating? So I think the answer to that is yes right now. I think two is the issue of reinfection. So are people who have been vaccinated getting reinfected? And like I showed you the breakthrough infections so far, we're really seeing minimal numbers of people having breakthrough infections. We will continue monitoring them. If those go up, then we might get concerned that we need a booster at that point. So right now, when we look at the reinfections we're looking at, when they occur, whether there is an increasing frequency, and then we will look at a kind of a mathematical model to figure out a risk-benefit kind of analysis to determine when a booster is necessary. So, but that being said, when we hear that Pfizer and Moderna are developing a booster, that's great, because at some point we may need the booster. So we want them to go ahead and be developing these boosters, and also have kind of the regulatory pathway in place to make sure they can do that. So, but I don't believe we will need a booster certainly this summer. It seems like we may not need one. And it also appears that the number of neutralizing antibodies that our bodies are producing to the vaccines are really robust and last at least 6 months, if not longer. So, so, you know, and much better than natural infection, I should say too. So if you've been infected yourself and you have your own antibodies, the antibodies our vaccines help us develop are much more robust than the ones from natural infection.
So just, I mean, like, so overall, what I'm hearing is that, you know, vaccinated person, it's relatively safe to return to an office environment. That, you know, if you're, you know, taking your precautions, as you say, in crowded areas or bottleneck areas and stuff. I suppose, I mean, the last question I would have though about my own safety is something like a strain develops, say in India, or like the Brazilian or the South African strain. Is something going to suddenly develop and we won't know until it's too late that the current vaccines don't cover it? So it would come into New York and spread rapidly.
Yeah, I don't think so, because I think that we've just gone through multiple surges in the US, and I think our systems are pretty robust now between public health departments and hospitals and clinics, so that if we, and laboratory systems, so if we end up with a large number of infections, you know, we will know, the public will know. And quickly, I think now public health departments will work with governments to help shut down areas. And, you know, then we like I said, these boosters are kind of ready to go. Like if we do find a variant that it outwits the vaccines, you know, I think we have a pretty good idea of how to deal with that now. There's a lot of funding coming from the federal government to public health departments right now to deal with COVID. So there is going to be continued surveillance on COVID, because we're not going to attain that herd immunity, because it's going to be endemic. You're going to have these COVID response teams in all state and local health departments that their whole job is to be on top of what's going on with COVID at any given time. So I do not think that we will be caught with our, what is it called? I'm not good with the cliches, but with our hands in the air. You know, I think we will know if infections are going up and transmissions are going up. We have lots of metrics to help figure that out. And I think, you know, we'll be able to. Yeah.
So if you learn it, sort of like, you know, best practices worldwide, like to me, and the two of the countries that responded best to COVID were Australia and New Zealand. And they did massive shutdowns very quickly. And as I understand it now, in Australia, if there is an outbreak of even one case, that city shuts down immediately, and or a particular region will shut down. And for a country that actually, you know, I don't want to get into politics, but does have a more right-wing conservative government, that was their action plan, and it's been pretty successful, I think. My worry in the US is that politics comes too much into the play. So there may be these departments set up by the federal government in every state, but you may have a state governor who goes, no, business is always, and won't shut down their state, even though it's very apparent to public health workers that it needs to be done.
Yeah, no, I think that it's definitely a concern. I think that we know a lot more now than we did last year at this time about this virus. So things like washing all your groceries, like you will not see that kind of messaging, right? So in a situation where there's an increase in cases again, we will know exactly what to do in that situation. We will know everyone has to put their masks back on. Everyone needs to, you know, isolate from each other. Right. So I think that because last year we were dealing with an unknown virus where we didn't understand transmission dynamics, and people saw the scientific method in play, right? Everyone saw scientists and how they struggled with what the messaging should be, and should we shut down schools? Should we not shut down schools? Or all that stuff, I think now is much more clear. And I think the messaging will be much more targeted. And I think that's one reason why you saw Fauci this weekend say, maybe we can take masks off soon, because I think the idea is we want to be able to have the masks in our back pocket to come out again if we need it, right? We don't want to just say wear a mask forever, because a lot of people aren't going to do that. So, you know, I'm hoping, and politics will always be a problem and will always play into this, but hopefully we can open our economies back up and make sure they're robust as we keep one another safe as well. And we'll, you know, time will tell to see how that plays out in various locations in the country.
So, I mean, like, to get to the very, I mean, there's probably no easy question to this, but like, how do you know when a pandemic ends? When does the World Health Organization go, pandemic over?
Right. Well, there was a data point. Let me find it. Well, so first of all, a pandemic ends when there is limited transmission occurring, right? When you just don't have as much transmission occurring amongst people, and the variants are no longer successful at causing severe infection disease, right? So right now in various parts of the world, including places like India and Brazil, we are seeing variants being able to cause severe disease and infection. So this is why we're still at the end of the pandemic, right? And I think this highlights the fact that two things can end a pandemic: global infection, where everyone gets infected, where we will certainly have a large number of people that will, you know, will die, or we have a very high uptake in vaccination. And I think this is where we really have to understand how important it is for each and every one of us to evaluate if we can get vaccinated, because vaccination will end the pandemic. Now, what numbers are we talking about? You know, so Dr. Fauci provided a metric on April 16th of 10,000 cases in the US, signaling at the end of the emergency. That doesn't mean the end of the pandemic, but the end of the country being kind of on edge because we're in the middle of an emergency. And my colleague Monica Gandhi at UCSF is saying that that already had happened in Israel and could happen here by, you know, even Memorial Day weekend. So, you know, we have to see where infection rates are, what our test positivity rates are, that will help us understand if we can increase kind of interaction amongst people indoors, and when we can start taking masks off. So again, I don't think that we really should be talking about COVID-19 going away completely. We're talking about instead, when can we get back to, you know, relatively normal ways of interacting?
Right. Which I think is what we're all sort of hoping for in a way. And I suppose, you know, like, I mean, I could keep going with questions, so I should give you a little break, but I do think that, like, the one question I suppose have is like normality for a lot of people is international travel too. And do you get to a stage, like, I mean, obviously we will eventually get back there, but like this coming summer, I hear mixed reports about traveling overseas, like going to, whether it's Mexico or India or parts of Europe. And I just don't know if you've heard, oh, you have a slide on it. So like what you've heard about it.
Yeah, so we do. So if you're fully vaccinated, and I know this is not the case for some families, but it sounds like maybe your family will be fully vaccinated soon with the kids being vaccinated. But fully vaccinated people, we believe, can travel, certainly in the United States, and they can travel internationally without getting a test before travel, unless it's required at the destination, which may be the case in a lot of different places. We also don't think that fully vaccinated people need to quarantine when they come back. So if you go to Ireland and you come back, if you're fully vaccinated, we don't think that you actually need to quarantine. You can go back about your business. Right. And let me just say, this is showing you how strong the CDC believes in these vaccines. If you don't have to quarantine after you're exposed to someone with COVID, or you don't have to quarantine if you've been to an area with a high rate of transmission, that's how good the CDC thinks these vaccines are. But many flights are still requiring a negative COVID test before you board a flight to the United States to, you know, get back here. So you might have to get a test a COVID test 3 to 5 days after returning from international travel. So, I think fully vaccinated people can consider travel again, even potentially to places with high rates of transmission. But you may not want to travel to a place with high rates of transmission just to put yourself at risk and expose yourself to a variant that your body hasn't seen before. So, I think that we can think about traveling to places that certainly US travel, given rates are so low everywhere in the US right now. But I think we can also consider international travel. In fact, I think it's really hard to book like anything in Europe right now because everyone's trying to travel. So I think it's hard to travel at the moment just because you can't find. I think in Hawaii, it's like hardest to rent a car at the moment. You can't rent a car in Hawaii because it's very expensive.
Oh, that's so interesting. Yeah. I heard, I know there's still a lot of staycations going on. So like the summer houses then, on the shores or up in New England and stuff are sort of booked out. I do just one last thing is just like when you said like infection rates across the US are so low, does that not feed in a little bit to perhaps some states where they opened up earlier, threw masks away, like Texas is an example, or a state where, vaccination rates are below 50%. It's like, what, look, it was all a bit of an exaggeration anyway. Look, we're fine, even we're not.
It's really interesting how, there were states like Texas that lifted a mask mandate early on and, haven't seen it as much of an increase in cases. You might argue that a lot of those states like Texas, because the weather is favorable most of the year, a lot of activities are happening outdoors naturally anyway. So and we know the rates of infection outdoors are so much lower than indoors, like I think it's 19 times lower doing an activity outdoors than indoors. So that may play into it. There also may be a lot of people who aren't getting tested with mild symptoms of infection in a place like Texas as well. So it's hard to hypothesize about why that is the case, but I think from a public health standpoint, when rates are, well, first of all, we know masks work in decreasing transmission. We have maybe hundreds of studies at this point that show us if there is an outbreak of SARS-CoV-2, of COVID-19, the way to limit transmission is via a mask. And it doesn't even have to be an N95. It could be a surgical mask, whatever. Masks really decrease rates of transmission. I think that cannot be denied. And there are also some places in Texas where people have continued to wear masks. So even if there is no mask mandate, for example, I have some clients that operate in Texas, they're still telling their workforce, to wear masks, right? So like Macy's, Target, all these places, if you want to go into one of these stores, you still have to wear a mask, even if you're in Texas. So it may be that, the private sector has kind of gone around what the government is saying in some of those locations and still required masking, and people are willing to do that to shop at those stores or to interact with those companies. And so people have still adhered to some masking in those situations.
Yeah, I'm going to wrap up here. And one, obviously, thank our participants for joining us today. But Dr. Trivedi, truly thank you to yourself. I mean, over the last 5 months, we've had featured different topics, and I have learned so much from your wisdom and knowledge, and I've really appreciated it. And I know others have spoken to me after some of these sessions and said the same. So we're incredibly grateful that you've kind of guided us to this point in the pandemic, and hopefully numbers will continue to drop, and that we will get to a stage where we can actually declare that this sort of pandemic is over. I wouldn't be surprised though if we have you back in some form, shape, or other in the near future as we sort of continue to navigate and get back to normality.
Yeah, I really enjoyed working with you all. And I think as behavioral health providers, your providers have such an amazing platform with their own patients and clients. And so it is important for us to make sure that we educate the behavioral health providers because they are so trusted by their patients. So it's been a real pleasure, and I hope that we've swayed some people to get vaccinated and at least provided people with some information to at least provoke thought on and battle some of the misinformation that is really rampant right now around COVID-19. So I've really appreciated the collaboration.
Great. Well, thank you all, and enjoy the rest of your day. Stay well.
Bye.